I'm the Workforce Development Manager at Brisbane South PHN, and I just would like to thank everyone for joining us this evening for our education session, Preparation for Living with COVID-19, Infection Control Update and Mask Fit Testing. Firstly, I would like to acknowledge the traditional custodians of the land on which we live and work, and of the many different nations across the wider Brisbane South region. We pay our respects to the elders, past, present and emerging, as the holders of the memories, the tradition, the culture and the spiritual well-being of the Aboriginal and Torres Strait Islander peoples across the nation. We acknowledge any sorry business that may be affecting the communities as a whole. In the spirit of reconciliation, partnership and mutual respect, we will continue to work together with Aboriginal and Torres Strait Islander peoples to shape a health system which responds to the needs and aspirations of the community. So firstly, a little bit of housekeeping for our session tonight. So you will notice, all the participants, you are muted and do not have your webcams available. We have quite a large number of people joining us tonight for this session, so we find that it's less disruptive that way. Questions though, we welcome your questions via the chat box. So if you've got questions throughout the presentation tonight, please put them in the chat box and we will be monitoring that and answering those questions as we go through. We're also recording the webinar tonight for those who aren't able to join us, so that they will be able to view it later. So let me introduce our speakers for this evening. We've got Margaret Jennings, Mark Regis and Karen Poynton. Margaret will be providing us with an infection control update, followed by Mark, who'll be providing information on mask fit testing. Hi, Mark. And Karen, who's going to talk about how Brisbane South PHN can support people in the Brisbane South region with mask fit testing. So we'll get straight into our first presentation. So I'll introduce Margaret. Margaret's a microbiologist and infection prevention and control consultant and educator. As a microbiologist, Margaret has worked in clinical and research, bacterial, viral, immunology laboratories, and has been a lecturer, tutor and demonstrator at a tertiary level. Margaret's interest in infection prevention and control started many years ago when she reviewed the use of chemical disinfectants in hospitals. In 1994, the National Standard for Instrument Reprocessing was released, and that attracted her interest in application for office-based practices. So I'm going to hand over to Margaret to start our webinar for this evening. Thanks, Margaret.
Thank you, Susan. And I'm just working out, can you take me off the bottom panel and put me into the middle? I think
we can see you perfectly, Margaret. You can keep going. You've got half the screen.
Okay, I'm not looking at what I'm saying is I'll have to got to keep my glasses on. I can't see myself except for this, and just when I'm putting on and taking off the PPE, I'll need to have a fuller screen. So I've got about 12 panels of, and I know this is boring everybody else, but I've got all SC, MR, J, DP,
yes,
all that all over the screen. Can you get me up onto the screen?
No, unfortunately. I think that's how, I don't think I can change that setting for you.
Okay. All right, I'll keep my glasses on and just tell me if anything's not clear, because I'm looking at it from a distance. So welcome everybody. I'm in Melbourne. I will be flying up to the Gold Coast and, contaminating you all on Friday. Hopefully I won't be. I've got to have my PCR done Wednesday. And interestingly enough, I've got to have another PCR done on day 5. Well, I'm returning on day 6, so I don't know when I'll get the result. But I think I'll actually have my PCR done on day 4 to get back and hopefully still negative. And I will be wearing a P2 mask, Mark, on the plane. So if anybody's asking, why would you wear a P2 mask or P2 respirator mask? And the answer is I'm in a confined space with plenty of people for an amount of time. So what ups risk all the time is distance, time and air. So that really introduces the risk Okay, time, distance, air, every time, just comes down to that. Now, on our side, we have the immunisation. We know that no vaccine's 100%, and we also know that we're getting some, I won't say, we're getting some breakthrough infection. So we're not having necessarily immune escape, but we're having some breakthrough infection. That is where some people who have been immunised are getting it. And I've got fairly personal evidence there, not in my household, but in a very close household, where the little one, the 3-year-old from childcare, got crook and had a test and was positive, but they already knew at the childcare centre, literally that day, they were beginning to get positives. So he got it, being a 3-year-old, and his mother got it. Now, she was double vaxxed, and she said, well, if that's a mild dose, being fully vaccinated, I don't think I'd really like to experience the full deal. So that's for those of you who, and I know that you guys are all vaxxed, but for those of you who are working or living with people who really don't see the point of it, believe you me, this is not a cold. Now, not everybody, of course, who's exposed to it will get it, but this is a fairly infectious variant, the Delta. I won't talk about Omicron for a little bit, but Delta is highly infectious. And so last year when we had the Alpha and even the ancestral strain, maybe one person might have transferred it to 1 out of 5 or 4 people in the household. This one, try 50, 60, 70% of people in your household will get it. So if they're not immunised, they'll get it, you know, much more severely, but it's a bit hit and miss as to who might get it when they've actually been immunised, but they certainly don't get it as badly. So we've got plenty of virus to share, for sure, but what we've stopped doing is looking at our daily figures so much, and I know you guys are probably at that obsessing thing at the stage, but for us, we look at our hospitalisation. Now, I know currently in Queensland you're hospitalising or have been hospitalising every positive case. My guess is that will stop. We have a limit here of about 600 beds available for COVID, and we're at about 300 now. So we're travelling okay. We don't expect it to go up much. So what I'm saying is that right now sitting on between 900 and 1200 a day, and we're now in our 3rd month of doing that. So you can see we've had about 80,000 positive cases. Now, they are infections, not necessarily diseases. So I think you can appreciate a number of these people who turn up with a positive don't have symptoms, but they simply happen to be a close contact, and they've got no sign of that. In other words, no sign of disease. But in fact, they have to stay put for about 5 days here if you've been immunised. Now, I know that bears, or that has some bearing on one of the questions, which is about close contacts. And we basically, the department is not actually contacting necessarily every close contact at all now, but they're saying to people who are positive, who have you been in contact with, and start contacting them. So there's only a certain amount you can do when you're getting 1,200 new cases. So it's not like, oh, we've got 1,200 cases, we've got another 1,200 today. So the department becomes quite limited. But I tell you what, it's a pretty good outfit in that they are calling people who are positive, and they're calling them every day to see how they're going, and then doing a handover to their general practice or, off to hospital. So that's where you are going to be soon. So I would say that you're not going to be putting all your positives in hospital soon. And then that's about, is the person who's positive able to be in a house without necessarily having direct contact with other people? And you might say, well, what's the point? Surely they've all begun to get infected. Well, it is worth trying to protect other people. And so what you might do in a house where you've got a positive case and everybody's vaccinated is that when that positive case leaves their bedroom, they wear a mask. To be in the rest of the household. Try not to be doing it all the time, but you can see where it's a family, that's pretty difficult. But they certainly wore their masks in this particular household that's close to me that I was referring to. And would you believe the 5-year-old who you couldn't have kept still for 3 minutes anyway? Thank God she didn't get it, because I think they would have had to have, locked all the doors and windows. She would have escaped, I think, and run off down to the park and the department would have been after her. So thankfully she didn't get it. And so she was, maybe she doesn't like her little brother who's 3, maybe she doesn't hang around him very much, but no, she didn't get it. And the husband, he didn't get it either. And they all tested. They had to be tested every second day. I think they had about 3 tests. And then we don't even in fact wait much more than that. Once you're vaccinated, you can begin to mix again, probably I think on about day 6, something like that. So that's just giving you a bit of a forward idea. But in fact, what does prevent transmission? And it's not PPE that has a role, but that's not the, that's not the be all and end all. And really it's about being aware. And although somebody might say you can have 30 people over for Christmas Day, there won't be 30 people at my place. So we in healthcare actually take quite a proactive approach to how we mix with people, how many we mix and where we mix. So most healthcare workers in Victoria are really avoiding large groups because it is a pain to be told that, oh, you were at that particular club or that particular bar and there was a positive case and now you've been contacted by your friend and said, we're all around that table, we're all talking loudly. And of course, you don't have to wear a mask indoors when you're drinking and eating. So most of us are choosing to eat and drink outside. And it's a fairly warm day and evening tonight here in Melbourne. So the place is going gangbusters. I can tell you that. They've been a bit cooped up, as you can appreciate. But having said that, people found ways, even when it was really cold, to be outside a lot, which I think is, there's a real strength there. Your issue is people want to be inside in aircon and stuff like that. But now I think about pools and stuff like that. So we talk about these hierarchy of infection controls and what can we do to minimise risk. So I'm thinking of you in general practice. And the first thing I would do is actually say, well, when we all wake up each morning, how am I feeling? Have I got... it's interesting because sneezes, for those who are immunised and for kids, I can tell you that runny nose and headache is quite right up the top there, and a fair bit of sneezing too, can tell you that. So a bit of a change there if you're not vaccinated. You might experience more. So of course there are many symptoms and you know what they are, but definitely runny nose is up there when you're immunised or you're a child. What we do know about the immunised person versus the non-immunised person, even though there may be a day during their infectious period where they're pumping out the same number of, the same viral load, the infectious period in the immunised person is much shorter. It's really only a couple of days, whereas it could be 6 or 7 days for the non-immunised. Same with kids. It looks like kids have got a fairly short infectious period, so up and down, and it simply means, and I've heard Jeanette Young say this, it means that there's about a 1 in 4 chance if you become infected as an immunised person, 1 in 4 chance that you'll pass it on, not necessarily 1 in 2. So you are less infectious even if you become infected. So we really talk in Melbourne not so much about who's got infected but who's actually sick. So if you don't get to hospital, we don't consider you that sick. Some people are whinging about that, but too bad. Bit of toughness. So the hierarchy starts with you when you wake up. How am I travelling? How am I going? I would adopt a buddy at work, and before we go inside, how am I looking? How am I feeling? Any of those symptoms. Sometimes when you wake up in the morning, you kind of start to imagine stuff, but by the time you get moving and you're with somebody in an hour or so, I really do think that that's worth it. Also, what's going on in your household. So, you've got to grab those teenagers who hide in their caves and say, listen, we work in healthcare and we want to know if you guys have had any close contacts with cases, but more than anything, have you got any symptoms? So this costs nothing, and it's what I call the lowest hanging fruit. So not only do we do our patients, we do ourselves and our household, and that will honestly stand you in good stead. You don't go crazy doing it. You just go, this is what I do. This is what I do because I need to keep risk low at work because I don't want to have to be closed down, not only because of a patient, but because of staff. And the place where this is being spread staff to staff is in the tea room. So we don't use tea rooms in Victoria much. We grab our cup of tea or, sandwich from the fridge and we go outside, either to your car if you don't want to be bothered by people, or you find a spot around the back or in the park. And that's actually quite important too as a break. Critical that people get out of that place or just get away from work at least a couple of times a day. And that sort of then leads me to how you would then work your breaks with your PPE, because you don't want to be changing your PPE out of sync with your breaks. So I do want to talk about that. So the hierarchy is symptoms. And yes, we know that, you know, around a third of people just don't exhibit symptoms or deny symptoms or have them so mild. So that's quite typical of a viral infection. No matter how much we try, we can't infect everybody. They don't have a stamp on their heads, don't infect me, but we know this is fairly typical. But we usually get enough of a clue by who you're mixing with, or, you know, the case will say, am I positive? Oh, yeah, somebody I know was positive, and, oh, I'm positive. Oh, that's a surprise. And been wandering around. Well, we don't want them to be passing that on to, you know, my transplant, my pregnant woman, and all the people who may have been immunised, but for whom the immunisation may not have worked as well, which is the whole point of still taking some precautions, even when you're immunised. If I say that in our population, about 3% of people are quite immunocompromised, compared to, you know, some say 30% in a general practice among your patients, pretty high. So that's the first thing I would do, is about symptoms. Yes, you can take your temperature, but, you know, it's about where you take it. Is it under the aircon or outside? But probably only about 30% of people will spike a fever. And with those who are immunised, it's possibly even less. So yes, it's one of the things you do. And you know the list of symptoms. So gut symptoms, yeah, gut symptoms are a bit more common than you might have thought. What I can also say is I have my little chart. So looks a bit like Maslow's triangle. So it actually says at the top, elimination, substitution, engineering. So what all that says to me, because I go engineering, what it really means is that I'm actually going to run my clinic so that people are not going to be sitting in the waiting room. Because if I've got somebody sitting, that is time. They're staying there for an amount of time. I've got to avoid that. The only people coming into the clinic are to see the doctor, and the doctor is ready to see them. If they're symptomatic, I don't even want them in the practice. You might think that that's mean, but the work that's involved, if you've got a symptomatic person coming into the practice, and I know that everybody tells a fib every now and again, and they don't want to tell admin that they're symptomatic and they wait till they get in front of the doctor. But most people are pretty good. And I think at admin, I'd be saying to people on the phone, look, you know, tell us if you've got symptoms. We still see you, still come, but we just do it a bit differently. And that's when I'd be saying to the person when they call to say that they've arrived, because they call, they don't necessarily walk in. So you've got to have somebody, you know, like a Nurse Ratched there at the door, not to sort of let everybody in. I think saying to people, don't come too early, or, you know, we'll call you if we're running really late, or look, there's a little bit of a wait. Are you comfortable in your car? You know, do you want to go and get a coffee? All that sort of stuff we've been doing. Don't say it can't be done. We've been doing it, because you see, the only other alternative is to stack your waiting room full of people. And I know you might say, well, we've got 1.5 metres, but 1.5 metres is nothing for this virus. And if I've got somebody really wearing their surgical mask pathetically, like, you know, this is where I can't see, but a big gap, no good. And in fact, if you wear your mask like that, or like that, that will be called a breach. And if you do have a positive case in the clinic, it's almost the same as not wearing a mask. So the way to wear your surgical mask is about a third of the way down. That's the correct way to wear it. If you're going to wear a cloth mask at work, you need about 5 or 6 for the day, because as soon as they get wet, they're not working. Same for this. All right, so flat. The only people who would twist it would be if these two bits were pinched, and it's usually people who've got small faces, but you just wouldn't do this because the air will just fly in there. You want the air to come through here. Same with this. Hopeless. All right, that you might as well not have it on. So if you want to give your patients a hard time, go for it. To take it off, it's loops, whoops, away and down and into the clinical waste bin, not onto the coffee table. Do your hands, always do your hands after taking your mask off. Now, going back to these order, So we've got symptoms. We've got what are we going to do about people not waiting anywhere. The only time they're going to be in the clinic is as we take them straight through. So you go, well, I'm in reception. What do I wear when I take them straight through? Well, certainly here, all reception here are wearing a minimum of a surgical mask. They've usually got a sneeze shield, and a number of people are wearing the face shields. I'm looking forward to seeing whether we're going to abandon the face shields, but we've been wearing those in admin because of the numbers that we've had. So generally admin have been wearing a face shield and a surgical mask. So the admin greets the person. I would be giving my patient a fresh mask. If they haven't been wearing a mask, they're not coming in without a mask. Now, you might say, oh, it doesn't say that in our guidelines. Well, we need to get ahead of that because it's too late when you think, oh, we haven't got any cases here. It's too late because by the time you've got 10 cases, you've actually got 100, all right? The cases that you see today reflect who bothered to turn up, who's been, chased down, and you'll have more than that. So there'll be more than that circulating in your community, and you don't know where it's going to pop up. I was chatting to people in Longreach the other day, and I go, sorry, you're only a Qantas flight away from Brisbane, etc. So you need to really get in ahead of this. But the idea being that if I'm wearing the correct gear, or I'm attending to each patient as though they might be positive, then I'm in a good position should we actually have a positive, and you will have positives, and then I should not have to be closed down. So let's try to avoid a lot of that. And can I say there's been a lot of streamlining done about cleaning, which I'll talk about, and also about, when we furlough, that means we put staff off for a certain amount of time. We really kind of just don't even want to go there, and we don't want to do deep cleans. So all those poor companies, well, not poor, probably greedy, who set up to sort of do a deep clean for $6,500, they've sort of all, well, they're not around. And I'll explain how you can do a really nice little cleaning system that should be very protective for you, and that you should not have to close down should you have a positive case for that. So these are some of the things that I think it's worth sort of saying, well, this is what other states had to do, and let's learn, let's get to the shortcut in Queensland without having to go through all the palaver that we did here. So I've sorted my waiting room. It's not being used. Pop a couple of, palms in or something like that. Now, what if somebody comes to the door and almost, falls in, and they've got Buckley's hope of getting back to their car? Let them in, please. So let's be nice. And if somebody has to wait in the waiting room because they're just about, fainting, then them's the breaks. So I kind of say if I get it right 9 times out of 10, I'm pretty happy. In other words, every effort you make to reduce risk, you reduce risk. It's not a case of saying, well, what's the point? I let one person in, but you reduced your risk 90% by not letting the other 9 in. So that's the way to look at this sort of risk management. What else is there? Air. Now, if you've been brought up like I was, air conditioning was a very precious thing. When I was growing up, hardly anybody had it. But the rule was, if you have the air conditioner on, you must close all the windows. Well, you know what? The people who invented aircon never had to go through a pandemic. So we in Melbourne today have windows open, even though it's 34 degrees, and we have the aircon on because we need to be comfortable in general practice. So you might go, this is really sounding crazy, but I need air flushed. I need it replaced, and it needs to be replaced with fresh air. As soon as you open a window, you begin to get air moving around. We like this. So we, in our short version, 6 air changes per hour. That's our ventilation guidelines. So we're pretty hot to trot. Mark comes from New South Wales. They are airborne disease deniers there. I'm sure he'll have a bit to say about that, although his business is in fit testing. So hopefully, if he's marketing himself well, he'll be definitely talking about airborne transmission of COVID. But we do know that not just droplet, which is probably the most common way to get it, and certainly that's borne out with a lot of the the cases, but a little bit of contact. It looks like there's contact, not as much as what we might have thought. Last year we were madly cleaning the fingers, the fingerprints on traffic lights and all that kind of thing. We sort of don't do that anymore. and also some airborne spread. So we know that a closed room with very little air exchange, risk up. And if you're seeing patient after patient after patient, and a couple of those were positive and the mask wasn't on properly, and I am thinking of, okay, ICU or even ED, then yes, the risk goes up. So we make a really big effort in Vic to keep the air changed. And so 6 to 8 air changes an hour. 6 is great. And for a lot of you, all you need to do is to go to the building operator and say, how many air changes are we getting per hour? Because most people don't know. Your home, for example, with just the odd window open is probably about 1 air change per hour, not even. That's just giving you an idea. In ICU, it would be 10 to 12 air changes per hour with about 40% fresh air. 40% of that is actual fresh. So you can see what we're doing is diluting the airborne particles in there. And that's important to achieve that. So that's, really one of our engineering controls. So as much as you give the patient a fresh mask because you don't want them to wear their wet 3-week-old mask, and we get them to do their hands, all that kind of thing, as much as you do that and as much as you do symptoms, there's also that attention to air. Now, when I think of the treatment room in the practice or a door that's closed, like the consulting room, I'm thinking, is the window open? Oh, there's no window. Well, what are we doing? We seem to have aircon. Well, where's it coming from? Where's the intake? So here's a little bit of homework. I'm not saying you've all got to be expert engineers. I'm not. But I have begun to learn that there's a place that you can go to for each building that you're leasing, and you can find out from the building operator or manager, janitor, etc. You want to know. Now, if it's your own place and you've got a split system in each room and you've got a window in each room, you'd operate your split system and have your window open a bit, okay, especially at the top, maybe a little bit at the bottom, so the air starts to dilute itself. Of course, it means that your aircon will probably start to go out of its little brain, but not too much. You can open that window. The other thing you can layer over that is an air purifier. So, they're about $800 each, not cheap. But what they will do is they've got a HEPA filter, and I know some of you had asked about that prior. And so the air in the room will cycle through that roughly every few minutes. And they, of course, will remove a lot of the small airborne particles, and they're an added layer, but they're not going to give me fresh air. So you've really got to think about, where's my new air coming from? So I've got to be comfortable. I can't turn the aircon off. I don't have a fan like that because that's just going to blow big droplets all over everybody. But my patient comes in and they just come in for their examination. So no sort of chatty. We can do that either by telehealth or on their way out to the car. So they've come in for an examination. They've come in for something that we can't do outside. And that's the other engineering control. What can I do outside? I can chat to the patient. I can do some telehealth. I can get an understanding of why they've come to me. So, for example, at my clinic where I live, when you arrive, you say that you've arrived. They ask you to wait in your car. They tell you roughly what the wait is, and then they say, Dr. Harrison will call you and we'll get some information from you. And in that call, Dr. Harrison can decide whether he's going to come to me, whether I even need to go in, or whether it's just a chat. And that's the way we're running general practice a lot. So we're not sort of stacking up the waiting rooms. And 1.5 metres for airborne spread doesn't mean a lot. It does for droplet spread, but I need to tell you that the smaller droplets can go out 3 and 4 metres. The infectious dose, that is how many particles of this bug we need to get sick, is, well, how long's a piece of string, but 1,000 plus. So and of course, the more infectious it is, it usually means you need less bugs. So with Omicron, you're looking at something that's more infectious, so I probably don't need 1,000 bugs to get it, which means it's going to transmit easier from patient to patient. It looks like it doesn't have the pathogenicity of Delta, which is what you want. So hopefully this is end game, famous last words. But really, a virus can mutate. Well, as you know, it mutates every time it goes through somebody. And what they think has happened a little bit. But for a big mutation, a lot of mutations, really big mutations in the viruses are lethal to the actual virus. So they go nowhere. But eventually or occasionally, a mutation occurs. That's just like a miscopying of the code, the RNA code there. A miscopy occurs and it is an advantage. It means it's quite agile. And you can talk about that as fitness, viral fitness. So, there is a view out there among the experts that we've probably reached peak viral fitness with this virus. But why they think Omicron has popped up, if it did indeed pop up in South Africa, is that, and this I think is relevant for us, for our immunosuppressed patients. So those who haven't got a great immune response, often through immunosuppressives, three things: they don't need as many bugs to get sick, they have a poorer outcome, and they take longer to get rid of to clear it. We call that clearing it. So what they think has happened in South Africa is that there is poor compliance among a lot of the HIV patients. And the virus has just kept on cycling, kept on replicating through somebody who's quite immunosuppressed. And eventually it's gone through so many cycles that it has mutated to become, this variant. So that's put forward at present. I don't have an opinion on it. I'm just relating to you what is one possibility. But it can really only turn, in on itself so many times to make itself more pathogenic. But historically, the viruses have evolved, and bacteria too, have evolved to become less pathogenic. And the host, that's us, and there are other hosts for this coronavirus, as you know, but I'll talk about the human host. And we evolved to become more resistant. And that's, it doesn't advantage the virus to be knocking everybody off, because then it's got nowhere to go, because it can only replicate in living cells. So right now, where it's replicating is in kids. About a third of our cases in Vic are in kids, because we can't immunise them until another 3 weeks, I think. 4 weeks, that's right, about the 10th of January. So what I can tell you is your numbers will, they'll go up, they'll plateau a bit, but by the time the kids get their second dose, which is about March, I think it's an 8 or 10 week gap, you'll start to see the numbers come down, and we really will reach herd immunity sometime in March. Okay, because right now, whilst everybody's saying, aren't we fabulous, 90%, I don't see 90%. When I look at the total population, I think we've just squeaked past 2/3. So we've got, I think, is it 2.5 million under 5? So we'll still have kids under 5 years old who it will circulate through a bit. But from the 5 and 11, we should really be able to get herd immunity by about March, April. And I would say both states all along that eastern seaboard. So you're in a good position actually in Queensland, because a lot of your people are what I call newly minted, fully immunised. So they got good antibodies, good T-cell immunity as they're now being hit by this. Whereas for a lot of us in Vic, we're coming up for that 4, 5, 6 months, and maybe we're getting that infection breakthrough that you're seeing now with the number. I don't know how many of the cases are in fact those who are immunised. I haven't actually read that. But what I can tell you is we look at hospitals and then ICU. And I think there's like one person in ICU who's fully vaccinated. And that person might be highly immunosuppressed. I don't know. There's been a little bit written about transplants and stuff who are immunised, and the information's actually quite good. So that's where the evidence is. It's not about the numbers of cases, it's about how many infections and how many ended up in ICU. And the number is like, most days there's like nobody in ICU who's fully vaccinated. So that's telling us something. So you say, what can I do to minimise risk? I've given you some clues there. And you see that I haven't really spoken much beyond the mask in terms of PPE. I will talk a little bit about the alcohol hand rub. And the trick here is you can't get enough alcohol, and I mean the stuff that you put on your hands. So always 2 hands. I haven't worn jewellery for so long, okay, around my hands. Bare below the elbows, etc., etc., and a bit of a swimming pool in there. Dip your fingernails in, and at the start of the day you can wash, but honestly, for the other things that you do during the day, what you want is this to still be wet at 15 seconds and just going sticky by about 20. So what we know is that the virus, everybody knows what that is, that has got a little fatty envelope, lipid envelope, and the spikes protein is sitting on that. So what we know is the alcohol affects the lipid envelope, but not if you just go like that. And it's dry in 5 seconds. You need that a good 15 seconds, wet contact for your hands, and be rubbing them all the way through. None of that, all rubbing. So I actually think a lot of people could do a lot better hand hygiene for sure. Now you need to also be kind to your skin. And so if you start at the start and finish of the day, and even when you change, your mask, etc., because it's wet, say you're going to change your mask at least a couple of times a day. I would also use that opportunity to do my hands in terms of hand cream. So same brand, keep it compatible. It's as cheap as chips. I wouldn't bother having it in my work, in the work environment. I might just kind of have it, maybe some in the tea room, but that's not where I'm going to sit, but as I pass by. So put a decent amount on. There we go. And work it in. So the time to do this is when you arrive at work in the morning, start your day with a hand wash, get all, the dog hair off and the kids' bits and pieces off. Wash to start, always wash at the end as well. But put the hand cream on. And what this is it's an emollient. Okay, and an emollient is skin softener. So when you start the day with that in your skin, it means that even though you then go to, use your alcohol and blah, 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 it just reduces the loss of oil and moisture. So I really commend that, At night.
Excuse me, Mark, I'm just a few more minutes and then we've got some time for questions.
Oh, beautiful. So how about I actually show you how to put that a bit of the PPE on. I just wanted to show, if I haven't already done so, there's my surgical mask, 3 layers rather, and it's the middle bit that's doing all the heavy lifting. This bit here is a bit hydrophobic, so the drops from the people coming towards me will stop there. This will trap, okay? And this part here that's near my skin, this will be for my breath. So that will catch my breath. But I need to wear this properly so that I think it's something like 97% of your air can go through that filter, backwards and forwards. With the P2, which I know that Mark will show, always do your hands first. This particular brand, I don't even know what it is, but I think that's the one that people commonly use, that shape. So this is one of the shapes that you can do. So it's onto the face. It's the you would put your gown on first, and this is if you're going to see a case. But most of the doctors in Melbourne are just wearing the P2 and the face shield. So why don't I just do that? Okay, they go out to the car if the person's actually symptomatic. So they put that on. Mark might have 50 fits. This first band goes around the neck. The second one goes on the crown. Then come round, and I'm going to do a very rough fit test, which I hope Mark will do a lot better. Actually, don't laugh, Mark. I've got it on upside down. So always be aware there's a nose bridge. There we go. So one on the crown, and I'll do it a little bit ham-fisted this time. One below, come around, mould it. Now there's a couple of tricks here, but try not to pinch it to make a V because that can be a bit tricky for you. Do a bit of heavy breathing. Then even putting your hands there, is there any air? Some people put a mirror up. what I'm trying to ascertain is, can I feel any air? If you've got long hair or furry hair, whatever, fuzzy hair, you can wear a cap. So to take it off, when you would be taking it off, you would do your hands. Some people do it like this, away and down. What you never do is touch the front of the mask, and you always do your hand hygiene after that. I also just wanted to show the face shield. If it's a reusable face shield, time for a break, and I do my hands and I take this off, and with my detergent disinfectant wipe, I clean, whoops, the inside, what was against my face. I turn this around and then I do this. Now, you wouldn't reuse this one, it's got foam. And then I would grab another one and I'd have just do the front and leave it nice and wet. I'm going to go off for my break. If I was a GP in Brisbane and the Gold Coast at present, I'd be wearing a P2 and a face shield. And I would change, once I've seen a number of patients and I think it's time for a break. You've got to have a break. You go crazy if you don't. Then, use that for hydration, toilet. Some people have an early lunch at, 11 o'clock, or some people have their lunch at 2 o'clock. But I would kind of break my day up a bit. I wouldn't be doing telehealth in all this clobber because it's not great. When I'm going to be cleaning, seeing the patient, and any device that I've used, like a pulse oximeter, etc., I take my gloves off, patient's gone, if you have had gloves on. And then you can put cleaning gloves on. It's a bit of a chore, but honestly, I think we can wipe the pulse oximeters nice and wet back in the drawer, stethoscopes, etc., etc. Do my hands. Gloves are probably overworn at this point, but certainly doing your hands. So I was just going to leave that there because there are questions that Sue's got for me.
Yeah, just a couple of questions, Mark. How is an air exchange achieved? And there's something that another question that relates to that. The person works in a medical centre in a big shopping mall with no window in the consulting room. How do they achieve air change? A suggestion has been that you leave the door wide open for a period of time.
It depends. Okay, so let's say firstly that the person is not going to take their mask off inside that consulting room. Like, I would be really making that quite clear. They need to be wearing it correctly, and that the doctor, whether they're wearing a surgical or a P2, the idea is the patient is there for face-to-face just for the necessary examination. The rest of it I can do on telehealth. They haven't come in for a big chat. You go to the building operator and you say, I want to know how many air exchanges. Now, they can't say 0. Usually they just don't know. But you're going to apply the blowtorch and you're going to ask, because until you know how many there are, we literally can't go forward, with that particular thing. So I would make that absolutely my first call tomorrow. You've got to be comfortable. We can't just sort of switch everything off. So what that means is they will have an intake. It's often on the roof. Fantastic. That means you're going to get some fresh air coming in. So it's a dilution effect. For the person asking the question, it's a dilution effect. And sometimes we actually can't measure it when the window is open. We just know it's happening because we can feel a current. Some people put in a little exhaust fan on the two little exhaust fans on opposite walls, with one pulling out, with one pulling air out, which means air must be coming in this one, and they get their change like that. I wouldn't overthink it, but I'd make tomorrow the day where I ask the building, well, come on, we're paying rent here. We want to know how many air changes there are. And also, where is the intake? And the intake will be, off the roof or from outside, which is perfect. If you want to have an air purifier as an extra layer of protection, fine. It wouldn't be the most important thing that you did tomorrow. I would really focus on people wearing their surgical mask correctly and wearing a P2, you might say, as needed. We wear them generally in general practice right now all the time, and that's the way we use them. We might go through 2 or 3 a day, just depending on how much face-to-face. But you can keep wearing the same P2 or mask and the same face shield for multiple patients, as long as they're not symptomatic, as long as nobody coughs on you, we call that extended use. And that's what I mean about when you take your break. It's not reuse. Reuse is where you wash it and hang it up and, you know, put your mask back on. We don't do that. But that is one way of getting through that. So that would be the first bit. I couldn't advise you until you've said to me, I've gone to the building manager and we're getting 4. So you ask them to turn it up to 6. But do you worry if they can't? No, you go, great, we're getting 4. That's better than 1. And then you might decide to put the air purifier over that. With the door being open, if it's open to outside or out the back, fabulous. For those of you who are in a standalone building, the answer is to open front and back door and feel that air. Once you feel that air moving past and on your face, you know that you've got air moving. Sometimes you can do it for a part of the day. Don't get upset if you can only do it, you know, every so often for half an hour or so. That is better than not doing it at all. And you're writing that down. This is the effort we go to stop symptomatic people, staff and patients coming in. This is the effort we go to get air exchange. This is the effort we go to get a fresh mask on a patient and hand hygiene. And this is the effort we go up to making sure that patients aren't too long face to face, and how we get people to wear their mask properly. That's the most important thing.
Great, thanks. Just one more question before we go on to the next presentation. Does random testing for your staff keep the risk low?
It's more a surveillance. So it tells you what's going on in your practice group, but it really didn't ever really stop an infection. Can I say, for this little family who are positive, they were negative on RAT testing. That's the rapid antigen testing. PCR picked it up as positive. And I need to tell you, if you're going to go down the RAT testing pathway, point of care testing, you're going to spend a lot of time on it. We're not doing a whole lot of it. In industries we are, you know, where they need a result before the guys start work. They might be in the abattoirs, for example, close together, a lot of noise, a lot of droplets. Test them every morning. With aged care, they'd thought about it and then they thought, oh my God, it's going to take half an hour, you know, to do every test. Who's got that time? And you can't always batch them. And so they often just take random PCRs 2 or 3 times a week, you know, from set people. I think all the staff end up with, is it 25% of your staff get tested every month, something like that. But with the RAT testing, sure, you can do it, but I need to tell you it's not as sensitive as the PCR, but it's not bad for a bit of a dive in to have a look, but be sure about why you're doing it. And of course, any symptoms beat anything, hands down. And if anybody in your family has symptoms, there's only one place for you and that person, and that's the testing station.
Yeah. Great, Mo. One last comment, thanks. Just a quick update on what is the current cleaning advice for a practice, and if they do have a case in the practice.
All right, now here's the good news. You never hear till about 72 hours after the patient's gone that there was a positive case. That's really good news, because that means you don't have to do a deep clean. I'm being cheeky, but I think you know what I'm talking about. But if add on to those other things that I said, and twice a day we do a high touch surface wipe. So I run around, you know, with my little pack of wipes, or you can use your ViraClean and a million pieces of paper towel, and I wipe over. We kind of start from the cleanest high touch down to the dirtiest, but I wouldn't bother. I would just use a separate wipe, and I think I can turn the wipe over enough times to do, say, 3, you know, 3 little touch pads, or another one to do 3 handles, 3 or 4, let's say. And so what you say is, as long as the surface looks clean, I wipe it over, and I call that my 2-in-1 step. So it's one step, and I'm cleaning, disinfecting. Then once a day, you would go over your broader surfaces, you know, and you can do that with wipes, or you can use your ViraClean. I think people are doing a lot less cleaning because the patients aren't going to the toilet. They're not there long enough to go to the toilet. Everybody likes that. Also, people aren't tending to use the kitchen so much. They're going out to their car, so there's not a lot of cleaning there. And the carpets or the floors don't tend to get as dirty because not as many people are attending. So there's actually some bonuses there. I'm a big fan of staff taking responsibility for their immediate area, you know, their own desks and their high touch surfaces themselves twice a day. Takes you about, 2 seconds to do each surface. So you might identify 5 surfaces just around you and then nominate somebody to do the broader shared surfaces, you know, twice a day. It takes about 2 minutes to do each one. And then the only thing that I probably wouldn't get so super keen about is vacuuming it all the time. I'd use my damp mop where I could. Certainly devices. So those of you who use devices, you know, pulse oximeters, whatever's, just get into the zone of wiping everything between every patient. Okay, and hand hygiene. But we aren't getting a lot of evidence of transmission, contact transmission that way, but in the environment. But we are in healthcare, especially where there's huge viral loads being plonked on keypads and stuff like that. It looks like we've got some evidence there.
Great. Okay. Thanks so much, Margaret. That's excellent. So we'll jump on to our next speaker, but keep the questions coming through, and we'll have a few minutes at the end that we will be able to answer those for you as well, I hope. So I'll just introduce our next speaker. So Mark is an occupational hygienist and fit testing subject matter expert with 3M's Personal Safety Division. So Mark will tell you a little bit more about his role when he starts his presentation, and we'll get on to that now. Thanks, Mark.
Cool. No problem. Thank you, Marg, and thank you, Susan. I just want to share my screen and make sure I got the sound button working there. It's always all right. Here we go. So yes. So thank you everyone tonight, I should say, for logging in. I'm going to spend a little bit of time, not too long, with you this evening, just doing, I guess, an introduction to respirator fit testing and a bit of a overview on, you know, the role of fit testing, the importance when we think in the context of PPE, and as much as Marg was saying, where it sits in the hierarchy of control, and couldn't agree 1000% more. It lives in the bottom because relying on people, relying on behaviour. We know how reliable that can be. But a little bit more about myself. So yeah, I'm an occupational hygienist. I work for 3M Personal Safety Division based down in New South Wales. I've gone through my Masters in Occupational Hygiene. I'm the current RespFit Chair, and essentially was the main driver of getting that program off the ground. And I've recently joined the Respiratory Protection Standards Australia Committee, and I've been on the Eye and Face Protection Committee for a few years now as well. So as I said, what is respirator fit testing? Why is it important? I'm going to touch on sort of some of the different methodologies, your qualitative versus your quantitative, some of the pros and limitations of each method, and having an understanding of what those things may be and what that context may be, and where it fits into the overall picture in your workplace as well. So I wanted to start off talking about types of respirators, and there's lots of different types out there in the big wide world of respirators. And as Marg was talking about those surgical masks aren't actually considered respiratory protective equipment. They are PPE, don't get me wrong, they absolutely have their place and their role about preventing the spread, which is why it's so critical for your patients to be wearing them and wearing them correctly. But when we're talking about respirators, we're talking about the intent to protect the wearer. It's going to come down to that tight fitting seal. So I just wanted to highlight here a couple of different types of respirators. You're probably most familiar with the P2 N95 disposable respirating or filtering face piece. We have powered air purifying respirators with a whole bunch of different attachments. We have what we call supplied air respiratory equipment. I just wanted to give you this overview of the different types, but fit testing applies to all different types of tight fitting face pieces. And when I talk about tight fitting, it's where we're actually relying on that seal, that tight fit, to create that seal to prevent anything coming through the sides, and everything that we're breathing in is going through the filter, because that is what's doing the job, the task of capturing those particulates. So lots of different respirators out there, but definitely going to be zeroing in on the types of respirators you are most commonly using today. And I wanted to, I guess, highlight and put the role of fit testing in context when we look at a respiratory protection program. Fit testing is an important part of a respiratory protection, but it is not the only part. It should not stand in isolation. It needs to be part of a particular program. We think about the selection of RPE, respiratory protective equipment. So we want to select a particulate filter or a particulate respirator when we're thinking about airborne droplets or aerosols. Marg made the comment around that airborne. Yes, certainly areas of New South Wales are a bit more denying, but I guess I'll make the comment as an occupational hygienist and from the AIOH sort of industry point of view, right from the word go, it was airborne transmission to how we think about things. Typically on a, in the industrial world of things, when we're thinking about dusts and aerosols and things floating in the air, we're concerned with anything that's 100 micron and down. And so we talk about inhalable dust and we talk about respirable dust, which is 10 micron and down. So right from the word go, certainly within the occupational hygiene community, it was very much, hey, this is airborne transmission and we need to treat it as such. When we start talking about ventilation, these other controls, and then obviously PPE comes into that as well. Now, when we think about tight fitting respirators, there's three key things I just really want to, I guess, emphasize. So when you're wearing your respirator, N95, P2, whatever brand it may be, I want to think about three key things that are there to give you confidence or assurance or reliability that protection is going to be there. So number one, you've got to wear it. I know it seems pretty obvious, but I know in my travels, in my time, and certainly in the industrial world of things, the amount of times I've been to a work site and the respirator sitting on a workbench or still in the PPE cupboard. Remember I went to a job site a number of years ago. I was doing some asbestos monitoring and the guy had a respirator on his forehead and one on his neck, and it's like, my gosh, you were so close, but unless it's there and on, well, clearly it's not going to be doing anything for you. It needs to be the right filtration. So whether we're talking a gas and vapor, but we're talking in the COVID context with airborne aerosols and droplets and those realm of things, it needs to be a particulate filter. It needs to be suitable for capturing the hazard that we're talking about. So we need that to be correct for the hazard we're talking about. And then fit. And this is where obviously I'm going to spend a fair bit of time in my presentation talking about fit, in that we need all these three things to be in place to be confident that this thing's actually going to be doing what we intend to do as part of our overall control strategy and trying to minimize that risk. We could have it on and have a really good fit, but if it's the wrong filter for the type of hazard, well, clearly that's not going to be protecting us. We could have the right filter, be wearing it, and not have a fit. So hopefully you can get the picture there. So when we're thinking about fit, that's the one with the biggest variable that is in your hands. And often I talk about PPE. Don't know if you ever thought about this, but what does the first P in PPE stand for? Personal. It's got to be right for you, the person wearing it. But on the flip side, it also relies on the person wearing it to do the right things as far as how it goes on, having it the right way up, understanding how to fit, where the straps go. That comes down to you as the wearer. Fitting a respirator isn't hard, but certainly there's things that we all don't know, and those simple things go a long way to inducing that confidence. So here's a picture I like to quite often show in my training, just trying to really reinforce this point of those three key elements of what's going on here. So let's go. So number one, he's got it on. Yay, thumbs up, he's wearing it. Number two, it's the right filtration for the situation. We've got sales an explosion and the concern was some dust and potential asbestos blowing down the street. But surely you've probably highlighted and picked up, we've got a very obvious issue with fit. Now this is definitely on the extreme side of poor fit, but clearly we can see we've got a nice big gap that's there, let alone the respirator being on sideways. There certainly are products that are out there that are ear loops. Maybe didn't want to mess up his hair, I'm not sure, but clearly we'll get into the facial hair side of things. So like this is a very extreme example, but I'm not trying to have a go at this individual, but clearly he's been given a piece of PPE. So for yourself, if you're being issued it or you're the one that's responsible for issuing the PPE, make sure the people you're giving to have that little bit of training, understanding on those correct things that need to be done there. So the level of protection this gentleman is getting, pretty low, if any, at all. But hopefully that highlights the point I'm trying to make there with those three key elements being in place. Now, a respirator, whatever brand, has filtration and goes through testing, but there's a lot of things that can impact fit. Facial hair for the gentleman in the audience is a big one, and I'll show a picture next, just trying to really reinforce about like the impact of facial hair. We talk about major dental work, so anything that's going to change significantly the face shape or the contours of your face to maybe how you've worn it before. That training and fitting skills, we talk about trying to increase our chance, our likelihood of achieving a good fit. Training and that fitting skill is so important to understand that. I mean, often I use this example where I'll say it breaks my heart as a health and safety professional, obviously focused in the respirator world of things. We'll see that picture on social media. There'll be that person, they've got their respirator on, they're saying, great, we're going to do some DIY work, but they've got the respirator on upside down. You know, and it breaks my heart in the fact that they've acknowledged there's a hazard, they've acknowledged there's a risk, they've gone out and got the piece of PPE, they've gone and put it on, and that last couple of percent, it all comes crashing down very quickly upon that. So as I said, fitting a respirator is not hard, but there are key things that we want people to know to do those right things. Makeup is another one that the Australian Standard talks about, and what they're trying to highlight there is that increase of anything that's on your face is going to increase that likelihood of a respirator moving and slipping around. You know, it could be sunscreen for the industrial worker, but just trying to get wearers to appreciate that these things aren't glued onto your face. You put them on, they're going to move, you're going to be doing a whole bunch of different movements, it's going to move as well. So things like makeup, depending on the amount, not that it's an area of my expertise, but certainly want to be aware of those kind of contributing factors. There's different products with different maintenance and designs. So we've got our disposable here, reusable, but the other big one here is PPE. Depending whether it may be safety glasses in your practice, it may be that face shield. There may be other, excuse me, other types of PPE, but where that respirator sits in context to what else you've got to get on your head as well, certainly will have an impact on that fit. The most common one, you know, I see is about those safety glasses where you may have it, you know, to get the respirator fit, it may be quite high up your nose, depending on the size of your head and nose and those types of things. But your safety glasses could be halfway up your orbital area there, or you wear your safety glasses correctly and your respirator is sort of half hanging down, which is not creating that seal. So being aware of all these things potentially can have an impact on fit that we want to be aware of. Talking about facial hair, excuse me, have a quick little drink. So this is a picture of one of my facial hairs from a little side project I did a couple of years ago, trying to, I guess this is a key challenge in many workplaces where they have a lot of males wearing respiratory, just trying to highlight the size of one facial hair to the size of a whole bunch of other different aerosols, particulates in that regard. So if we're talking about our 5 micron cutoff, 5 micron cutoff in this droplet aerosol, but either way, you can see the size of that compared to that. And you think about facial hair from every male, it's slightly different. The bushiness, the length, facial hair is a moving target. It grows every day. What it is for me today is going to be different tomorrow and vice versa. So, there's been a number of studies, and this is back from the 1980s. So this is not new evidence, but how much, facial hair can impact the expected level of protection. And when we're talking about high risk COVID pandemic situations and GPs, we want to be confident that what we're wearing, can achieve the seal, the protection, and having facial hair will certainly impact on that amount there. So there's all these different types of respirators, and the ultimate question is what respirator fits you that you're wearing, you want to wear, need to wear. So there's all different types of tight fitting respirators out there that all require fit testing to check that compatibility. And so the fit tests is a process of checking that a tight fitting face piece matches the person's facial features and seals. There's a whole bunch of different methods which we'll touch on, but ultimately what we're trying to find is a face piece, a respirator that fits you. Now, if you go through a fit test and a respirator doesn't fit you, that's not a reflection on you. That's not necessarily an individual reflection on the respirator, but think of it like a compatibility check. In that we're all different in that regard. We've got a very diverse culture, which is fantastic. We love that about Australia. But when it comes to these kind of things with fit, that has an impact. I remember talking to the Queensland regulator a couple of years ago now, off the back of the silicosis and the pneumoconiosis. Unfortunately, that was quite prevalent in a few states there. They got to this workplace and they had been fit tested, so yay. But the fit tests had demonstrated that they were unable to achieve an adequate seal or an adequate fit for them. They didn't do anything else about it. They just continued to wear the respirator, you know, and it's kind of like, well, hey, you've got evidence that this is not suitable for that individual, for these people, but you're continuing to wear it. So a fit test is a process to find a face piece, respirator that can fit you, that you're confident can keep that. Now, fit testing may be something that is new to your world of things. And I guess just trying to highlight the fact that fit testing is not a new concept. So this is a little video from the 1930s that I just thought I'd like to show to give you an appreciation, hopefully give you a little bit of a smile on your face, just to appreciate what's going on here. So hopefully you can hear the sound here.
Sizes of faces, it had to form a dust-tight seal on all types. The long and narrow, the medium, the round and full. To test security of fit, coal dust was blown into the air. They breathe deeply, trying to suck in all the dust they can. When the respirators are removed, the sharp white line must show not a sign of leakage around the facepiece. His face is dirty, but his lungs are clean.
So fortunately, the fit testing methods have improved slightly a bit from the 1930s, but hey, we're 90 years from this particular period where the understanding of, hey, this is really important to achieving protection. You're probably thinking, what about the guy who's doing the fit testing? Maybe he should be wearing a respirator as well. Absolutely agree. But like I said, just trying to highlight that fit testing is not a new concept at all in that regard. And why fit testing? I've kind of touched on a couple of these things, that we're all different. No one face is exactly the same. No one respirator is going to fit every single person. As a manufacturer, and obviously talking on behalf of 3M, that we don't say that, hey, this product is going to fit 100% of all people. Now, we know that many of our products fit really high percentages, but it's not 100%. There's going to be those, ends of the bell curve. We think about either small faces and very large faces are not going to fit there. So fit testing helps provide that confidence. Fit does go straight into respiratory protection, and is that process about individual attention to fit. So when we talk about when to fit test, when is that initial selection of respiratory protective equipment? Maybe it's a new face piece or a new style. Mark touched on having different face pieces, and certainly in the times of the pandemic, having being fit tested, or knowing a few different styles depending on the supply challenges that we're all facing at the moment. Certainly want to be fit tested in all those. Essentially, whenever there's change to the wearer or change to the respirator, and it is recommended annually through the Australian standard, ISO, US, because over time we change. Certainly there's been studies in the US and OSHA about how much that people have changed over a 3-year period to highlight that change, but it's also a good refresher period in that period of that fit test as well. So the most common fit tests that are out there that are, I guess, being deployed in Australia, there's 3 here. We have the qualitative fit test, the aerosol taste test, which is a taste test, as it is in the comment there. Yeah, so there's definitely face pieces that have different sizes as well, and that's about going through that process. That fit testing will help identify what size may not be suitable, which is just as important to finding which ones are. We have our quantitative, so ambient aerosol condensation nuclei counting, CNC, and controlled negative pressure, which is I guess a lesser known fit testing methodology, not suitable for disposable face pieces because it needs to maintain that pressure. But just wanted to highlight that one is in there. So I just wanted to show a couple of quick little videos here of fit testing in action, so to speak. I won't play any sound, but just to talk about each of the fit testing methods as well. So I'll just mute that and I'll jump ahead. So this particular one, so a qualitative fit test kit, 3M manufactured, but there are a number of manufacturers out there. We're just using a challenge agent, Bittrex or saccharin in this circumstance quite often, where we're going to be spraying into the hood to challenge the seal. Now, like each of these fit testing methodologies, there is a whole process, and specifically this one here, being able to determine we need to determine that the person that we're testing can actually taste the solution. If they can't taste it, well, certainly this is not going to be a reliable fit test, and we'd be looking at another method. So this is the sensitivity part that we're seeing here. We want to check that the person can taste it. Depending on how many squeezes it takes to taste, that helps us set our threshold, and that determines how many top-up sprays are actually given during the test as well. So like I said, these are based, these have been validated for many, many years. This particular fit test method has been around from the early 1980s. And then we're going to go through the process, and typically between the sensitivity solution, we're going to go and wipe down our mouth, clean it, wash out our face, because obviously we're going to have that solution on our face. Because what we're going to be going through these range of exercises, we want this person to be able to clearly taste if there is a leak. You know, often if they haven't done that process and wipe their mouth down, they will often, you know, the person being fit tested will be licking their lips and going, oh, I think I can taste it. I'm not sure. And we want to make sure that is very clear if there's a fit. So there's going to be a range of exercises. You think about you wearing a respirator, what you're doing with different patients and bringing people in, whatever those tasks may be. If you're not standing still like a statue. So each of the fit testing methods will have a range of exercises, typically in the qualitative one, your normal breathing, deep breathing, head side to side, up and down. So we're trying to move to the extremities to challenge that seal. You know, it's great if a respirator can seal when you're standing still like a statue, but that's not what's happening on the job. We're trying to replicate with that movement to what you do on the job, to what PPE you wear in the job, noticing she's wearing her pair of safety glasses during the fit test as well. So there's a whole bunch of exercises there. One of the things I really like about the qualitative fit test is the fact that it is a taste. So what you're seeing here in the video is often if they've gone through the test, haven't tasted anything, quite often in my experience, they'll be like, oh, you're not even spraying that much in there. I can't even taste anything. As soon as they pop that seal off and they get a big gob full of the Bitrex or saccharin, certainly they're going to go, oh, wow, this thing is actually working when I've got the right filter for the hazard and I'm achieving that seal as well. I'll go through the pros and cons just afterwards. I'm just trying to bring up the video for the condensation nuclei counting. This is probably the other most common method that's out there. So this specific method uses a particle counter, ambient aerosols. So it's counting the aerosols in the immediate environment where the fit test is taking place. So you see a little clear tube and a blue tube there. The clear tube is going to inside the respirator to count the aerosols that are getting in, and then the blue tube is counting those particles outside. So outside the respirator divided by inside the respirator gives us a fit factor. And I'll just pull it there. So one of the things Marg was showing before was about that user seal check. So I just want to add a little bit more technique to what Marg was demonstrating, is also wanting to cover the whole entire filter area. We're trying to force the air if there is a gap outside of those seals. If we're just putting our hands around there, you'd have to have a very, very extreme leak to feel that, because air is designed to go through that filter. So we're trying to force that air out. That's a positive user seal check is a breathing out. We're trying to push that out, may push out. And the negative user seal check is breathing in. And I'll touch on the user seal check later on as well. But just wanted to highlight that technique about covering the whole entire filter material, because we're trying to block that filter in that regard. Similar to the qualitative fit test is going to be a series of exercises. Now, one of the things with the aerosol taste test is subjective. We are relying on the person being fit tested to tell us if they can or can't taste the solution. Using a quantitative method, we're not relying on that person to say, yeah, I can taste it, or whatever it may be. So they're going to go through those exercises, and on the machine, whether it's a port account, it may be an AccuFit, there's a few different brands that are out there, it's going to give us some numbers about that reduction in exposure. This video is a UK video, so probably what you're noticing here is the gentleman stepping up on a step. That's something specific out of the UK protocol that typically you won't find in the OSHA protocol, which is mainly what people in Australia are typically following. You'll see that he's holding the tube there. He's got the neck strap on, trying to just mitigate that risk of the tube, putting that little bit of extra weight and impacting the fit there. So the machine will give you some numbers to say, hey, yes, we're achieving a good fit, or hey, we're not in that regard. So obviously we'd not have a good fit factor here. looking at that red one there. I'm just conscious of the time. One of the things I really like about the qualitative method, especially with the Portacount AccuFit, is this real-time feature, which is great for training. We can sort of put the respirator on and move your head around, and you can see that graph go up and down with that fit factor depending on how well that fit is being achieved. Let me jump back into here. So each of the methods have limitations in and benefits as well. So it's a real high level overview. One of the biggest limitations when we think about from a deployment into a workplace that you may be doing yourselves, it takes a bit longer than some of the other fit testing methods when we factor in the sensitivity process, wiping down our mouth, going to do the fit test back again. If you get a fail, you do need to go do the taste threshold screening process again. So something to be aware of. It is subjective. It can quite often be viewed as non-high tech. But each of these methods, when I say methodologies, there are a very set protocol of how to fit test. And one of the big things with the with the qualitative test is people, can start to cut corners because they think, oh, I need to get back on the job. I need to get this worker back on there. It's really critical that a fit tester follows that process because that is what the reliability and the validity is based upon. A couple of benefits of the qualitative, comparatively, it's fairly low cost. You're talking about $400 to $500 a kit. There's no power required. There's no adapters required. And you test the full facepiece plus the filters. This method is only suitable for half face and disposable respirators due to the equivalent fit factor that is required for a full face respirator. So that's where you may need to go to a quantitative method if you've got a full face. So one of the things with the limitation, probably a bit more knowledge on the machine and how to probe a face piece. There are very specific locations, to have that probe in. You are relying on an ambient particle concentration in the work environment. There certainly are, in the kits they come with particle generators because you are relying on a reasonable level. We don't want it too high. We don't want it too low. If you've ever done fit testing and you can't get your particle count up, you just want to throw those machines out the windows. I've done fit testing in the past and you're trying to shake curtains and the room was not ideal because it's a very big room. It does require a range of fit test adapters when we think about reusable respirators. You would have seen in that video, that disposable respirator was probed. So you will need to dispose of that respirator with a probe in it. We're obviously not going to use that on the job. But some of the great things that can test that full range of face pieces. It's got that real time that I mentioned. It's great to identify those fit problems as they move their head around in that real time feature. And from a record keeping point of view, having that electronic already built in with a database that you can transfer to computer versus, your qualitative is going to be more of that manual record keeping side of things. Like I said, there's pros and cons. All of these methods are in the international fit testing standards. The standards don't say one, this is better than another in that specific regard, but obviously there's pros and cons as are hopefully highlighted to where a workplace may make that informed decision based on their circumstances. These quantitative machines, you're talking the $20,000 to $25,000 range of things. And that's not going to be reasonably practical for every workplace to go and get one of those in that regard. So that's where that qualitative is going to be more accessible in that regard. But we still need to follow the process to be a reliable fit test. This is just a little picture highlighting just sort of which methods are suitable for what facepiece styles. I'd say in Australia, the most predominant method will be the CNC method, followed very closely by the qualitative. But once again, you'll come across all of those there. I touched on that fit test versus user seal check. They are the same. A fit check is not a fit test. I often liken the fit test is like sizing up a shoe. We need to make sure it fits, but it still relies on the wearer to do the right thing every single time as far as when you're wearing it, have you donned it correctly. Passing a fit test gives us confidence that a fit can be achieved, but it's not a guarantee. It still relies on the wearer, the individual. What's that first P in PPE? Personal relies on the wearer to do the right thing. And when it comes to fitting instructions, and Mark sort of touched on some of those really well, you know, there's tons of fit testing posters, there's YouTube videos that are out there. We have a series of podcasts that I've done. We have white papers and posters and guides to do the fit testing. So certainly don't want to make you feel like you're out there on your own with the respirators that you've got there. There are plenty of resources. Do go hunt them down. Like I said, fitting a respirator is not hard per se, but there are certain techniques that Mark, you know, demonstrated when we're taking it off. We don't want to be touching the filter. We want to be moving it away from our face. Where are we disposing it? Make sure it's going the right way up in that regard. So plenty of resources that are out there. So to try and wrap this all up, fit is a critical component, you know, achieving protection on the job. Confirms fit can be achieved, but still relies on it being worn correctly on the job. It's one part of a respiratory protection program. It needs to be selected appropriately. It can be really effective, but the effectiveness relies on the right selection, fitting the individual, being worn properly every time. And I think as Mark touched on as well, you know, PPE is part of our overall risk strategy. It should not be your only attempt. It's going to be a combination of all these things to bring that risk down as low as reasonably practical, with the understanding of what all these things play into do. Look, thank you for your time tonight. I'm sure if there's a couple of questions there. I also wanted to highlight my fantastic colleague, David is logged in. I'm based down in New South Wales, but David is one of our local contacts up in Brizzy there. So certainly we have, you know, guys on the ground and girls on the ground to come out and help you if you've got any specific questions around respirators or fit testing, and we can help you in that regard. So, yeah.
It's great. Thanks, Mark. I think just one question there. If you're the person in the practice that's in charge of the fit or the checking, the fit testing for the staff, and have had no training, is it appropriate just to provide the staff with information, resources, etc., and leave it up to them? Is it their responsibility?
Yeah, when we look at the work health and safety legislation, obviously the employer has that responsibility as a PCBU to have that person who's responsible for that to providing the right information. You know, it's not like you think, I was trying a simple analogy, but going to, you know, learn to drive a car, it wasn't like, all right, here's the user manual of how to drive your car, off you go and figure, you know, obviously we were shown by someone who had that knowledge and experience. So certainly reach out to the people you're buying your respirators from, if it's 3M or not. You know, the people I know that I deal with are always going to be happy to help that. We want to see people use these products correctly. It's very easy to think you're getting it right and you're not, got a gap where you've done something that, you know, mentally, you know, you think you're, yep, I'm doing it, but there may be something there. So certainly you'd be wanting to get maybe a bit more training education. If you're that person who's responsible to get a bit more education yourself, reach out to someone like David to just get a little bit more information, use those resources as well. I saw one of the questions about N95 and D95. N95 is a US filtration rating. So N95 products can be made all over the world. Obviously, a lot are definitely made in China. D95, I believe, is the Detmold product number in that regard. So D95 is more related to that. And I think they're a P2 rated, which comes out of the Australian standard. So N95 is that filtration rating. What the 95 stands for is that the test aerosol they use in the standards is what we call the most penetrating particle size. It's about 0.3 to 0.6 of a micron, and that's what the Australian standards uses the test size, and so does US and so does other countries. It's like worst case scenario. So an N95 will stop 95% of the hardest particle size to capture. When you kind of get above 1 micron, they're big in the scheme of respiratory protection and filtration side of things, and they typically will travel in a straight line and get captured really effectively. So if you ever want to delve into it, YouTube Minute Physics N95, and they have one of the most amazing videos just breaking down the physics and the science of how particulate filters work. So if you want to nerd out on some respiratory filtration stuff, there's my recommendation for the night.
Okay, thanks so much, Mark. Okay, so just before we finish this evening, Karen, who's a member of the Brisbane South PHN Primary Health Response Team, she is going to give us a bit of an update on what how Brisbane South PHN can support you. So Karen helps coordinate the personal protective equipment from the National Medical Stockpile. and she's helped source some limited availability fit testing options for general practices in our region. So Karen's going to tell you a little bit more about that. Thanks, Karen.
Thank you, Susan, and thank you, Mark and Marg. Really appreciate your time tonight. So just to give an update on what Brisbane South PHN is doing. So to support general practices in our region, we are offering eligible practices some limited access to P2 N95 respiratory mask fit testing. But because of our limited funding, we are prioritising that access to those fit testing options, and that's being prioritised for practices that have indicated a willingness to see COVID-19 positive patients or respiratory symptom patients, noting that we expect most COVID-19 positive patients to be recovering in their home or in the community, that they'll be supported with phone or video consults. But for those practices who have that greater infection control risk, they will be prioritised to access to our fit testing. And we're also going to maximise those fit testing options for practices that can share resources with other practices, larger practices that are seeing a larger volume of patients, and especially practices supporting vulnerable communities in our region. So we've sent out an initial expression of interest to practices that we finalised on the 7th of December, and we have started providing fit testing options this week for some limited quantitative fit testing appointments, and also access to a qualitative fit testing kit. And I'm sure you're all experts on the differences between those after Mark's talk. And the qualitative fit testing kits are coming with training on how to use them. So that's our current offering. But we're also looking to do a future offering. We put in an order for some more qualitative fit testing kits that we expect to receive in February or March next year. And we'll be doing a new expression of interest in the new year regarding these qualitative fit testing kits. Again, we'll be prioritising those practices with a greater infection control risk and practices that are able to share these kits with other practices. So, we might also be offering fit testing appointments at our PHN, because we're going to keep one of those qualitative fit testing kits. And we're also looking to be able to lend that out to practices so that they can use as well. So hopefully those options will help support our general practices in supporting COVID patients in our region. We've also got a comprehensive website, and I'll put that in the chat in a moment. We have a PPE and infection control page with lots of links, and we'll be putting a copy of this webinar and also Mark's slides on it in the next few days. And we'll also be updating it with some fact sheets from 3M and those videos, noting that, you know, these apply to other brands as well, but they give a very good summary. And finally, I just wanted to make mention that the PHN is able to continue to support personal protective equipment for practices where they have issues with their commercial supply. We are able to supply a limited amount of surgical masks and P2 N95 masks and goggles. At the moment, we have a low-risk PPE guidance per Queensland Health. And also probably mentioning that the goggles, sorry, not the goggles, the P2 N95 masks that we have, we currently only have two brands. We have a Multigate brand and a 3M 1860 brand. So, you know, that may or may not be a fit for your particular practice staff and face. So, you know, as Marg said, it's better to have a mask, and one that fits well is even better. And, you know, the gold standard and per the standard is a mask that's been fit tested. And what probably one other final thing to mention, the Department of Health have advised that they are looking at providing PPE bundles for general practices who will commit to seeing respiratory patients with respiratory symptoms. We haven't heard any more details about that, so we'll let you know when we do hear this. And we certainly haven't been given any extra stock for these type of PPE bundles. So probably a key message is to make sure that you're ensuring your own supply and supply that fits your staff. So that's kind of an update. Are there any questions in the chat? Can't see any, Susan.
No, I think I've got got a minute or so if anyone's got a pressing question.
I'm just going to put our website in the chat.
Great.
And that worked? Did that work?
Not quite yet. I think
any guidance on close contact or casual contact?
Yeah. The link's up. I would, yeah. I think Marg has had to leave us, so she might have been the best person to answer that question. Unfortunately, she's not on the webinar any longer, but I can forward on any further questions to her, and we can provide that information to everyone tonight. So I think that might be it. And
okay, yeah, we've got those notes. Thank you, Jodie. And yeah, Josh, we're doing what we can, and we've got the order forms on our website, and we're helping wherever we can with PPE requests. Probably one other thing tonight, it is coming up to Christmas. Our last order for our PHN is Monday the 20th of December, close of business. So if you're again thinking about your own commercial supply and if you've got any risks with that, but we can certainly help from the National Medical Stockpile, but you'll need to get those orders in before the Christmas closure by close of business Monday the 20th, so that it will be delivered before the Christmas shutdown of our distributor and also our PHN, and then we're reopening on the 4th of January and we'll be able to start processing orders then. So if you have any concerns about your supply of masks and surgical masks and P2N95 masks and goggles, please put the order in so that you are adequately covered for these coming few weeks.
Okay, well, I think that brings us to time tonight. So thank you very much, everyone, for attending, and thank you to the speakers for this evening. And we'll leave it there and see you at the next webinar. Thanks so much, everybody.
Thank you.